afternoon, everybody. You're really welcome, and it's great to see you here. Thanks so much for coming along and registering your interest in today's masterclass. It's my great pleasure to introduce my colleague, Professor Joseph Manning, who's from University of Leicester and Nottingham Children's Hospital. So he's a joint clinical professor, and he's here today to talk to us about life as a clinical academic. So his talk is very pertinent to where we're at currently within our own development and within nursing and midwifery and across the allied health service. So we're really looking forward to learning from you and sharing. You're very generous to share your expertise with us. So we'll take it away. So thank you very much. This will be available on recording as well, by the way. So
well, thank you so much for that lovely introduction, and I've had really an amazing time since I've been here since Tuesday, and I'm really appreciative for your hosting and for the warm welcome that I've had from colleagues across the university and also the hospital. So thank you. Yeah, I'm going to take the next probably 40 minutes to really talk about clinical academic careers from my perspective as somebody who's lived the last 20 years of their life in this space, and talk a bit about how my programme of research has developed and how that's remained clinically aligned, and then hopefully conclude with sharing some reflections that may be useful. I get a real sense that there's an appetite to really step in and lean into the space around developing clinical academics in Ireland. So it's quite an exciting time, and hopefully some of those reflections can be paid forward to your context. So I think just to begin around context, we are challenged, universally challenged, I think, by a number of things, and we are certainly in the UK engaging with a lot of system-wide change around how we organise and deliver care to a growing and diverse population, and how we work differently with partners to improve population health. So I think that is a challenge to do, but also a significant opportunity. And we have created, it's come into legislation, our ICS statutes, and also our integrated care boards. And it's sort of distilling down through the system as to how we're going to actually deliver care and what that care looks like. I think the other thing to say is that we've got a workforce that is changing. We are still largely affected by the COVID-19 pandemic, and I think that will be throughout our generation and beyond. We'll be seeing the effects of that. We're also contending with global positioning conflict that is also affecting how we develop and educate and support our workforce, and where that workforce needs to be, what's the composition of that workforce, and what are the skills and attributes of that workforce so that they can actually meet population health needs. And I think we've had clear signal from the WHO document around the tri-billion target, and there's even more policy posturing and guidance coming out as to what that looks like. But I think, you know, the health and well-being of our workforce is a particular priority, and who we've got in the right place at the right time to deliver that care is also under question. The third point is around increasing complexity. So our case mix, certainly since I registered as a nurse back in 2005, has significantly changed. We have got multiple long-term conditions that are dependent upon technology, and people that are living longer with more health conditions. And so how we deliver, support that care, what that care looks like, and how we are really aligning the healthcare workforce and the healthcare delivery to the conditions for today and also for the future is a priority. And then I think, again, this is a universal issue and compounded by the current conflicts, but we are contending with cost of living crisis. We need better care for more people, but delivered at less of a cost. So I think collectively, that proposes lots of challenges, but also opportunities. And I think we're probably all very familiar with the triad of evidence-based practice, but it comes back to this, that to provide better quality outcomes, better patient experience, more efficient and effective care, then we need a really robust evidence base to do that. And that cannot be a uni-professional endeavour. It cannot just sit with conventionally our medics and our dentists in England, at least, who have really quite robust and defined clinical academic careers. That needs to reflect the diversity of the workforce that provides and delivers and optimises care. So back in 2012, our Department of Health defined what clinical academics were, and I think that is a really great starting point, because it at least recognises and conceptualises an ambition for what this career pathway could look like, and fundamentally it's somebody who has meaningful concurrent engagement in clinical practice and research, leads at the bedside, mobilises that insight from that clinical domain to direct a programme of research, and then mobilises the evidence base that's generated back into clinical care. And since that document, we've had some really fantastic leadership. This is Professor Dame Ruth May, who was our former Chief Nursing Officer for England, who was a real advocate for clinical academics, not just for nurses, but across health and care professionals, and identified the real value in again, optimising the health outcomes, in driving the research agenda, and generating and translating that evidence base, and also that diffusion, upscaling and spread is really important. And she identified that was really the role of the clinical academics. Also under her tenure was the development of significant posts around implementation. So some of my colleagues, Professor Joanne Cooper and Alison Richardson, had roles within NHS England to really think about, okay, well, how can we operationalise that? And they developed a strategic plan for research, which didn't just talk about clinical academics, but also talked about the wider ecosystem for enabling research-intensive environments that were equitable and accessible for all. And I think that work has been foundational in really shifting the focus and making it more accessible to everybody, as in research. So whether that's research delivery roles or research leadership, but also aligning to some of the critical priorities around how we develop our workforce, and doing that in a digitally enabled way. Concurrently, there has been work from the Council of Deans, and my very good friend and colleague, Jane Code, has been leading that from a clinical academic implementation network, and also Ruth Endicott as the Director of Nursing for the National Institute for Health and Care Research. And on the back of some of the lobbying that they've done, is really brought to the consciousness of around contracting and trying to jostle between two potentially not commensurable organisations across health and HEI's FOLIC principles. So we had these principles around contracting and what terms and conditions would look like, and they were in existence for medics and dentists, but not for other health and care professionals. And certainly the Council of Deans and other organisations have lobbied hard to bring this in line for our professional groups. And then the other thing that Ruth Endicott has done was mobilise £50 million worth of government investment specifically for underserved professions. So that's nurses, midwives, allied health professionals, and the wider health and care community, and ring-fence that for funding fellowship schemes, but also the NIHR portfolio, Research for Patient Benefit, Health Technology Assessment and Programme grants, which has been absolutely enabling and really starting to level up the playing field for health and care professionals, and particularly clinical academics. I think what we've also seen over the last decade is a growing evidence base around the benefits that clinical academics can have, not just at individual, but also at service and organisational level. We're cognizant of some of the barriers, and some of those have barriers may be knowledge and attitudes towards clinical academics, but I think that is certainly within the organisations that I work is being moderated because they're realising the impact that clinical academics can have. But yeah, there's more work to be done, but at least there is a growing evidence base to identify the value that clinical academics can bring. So that's the context, and I think that is really important to sort of outline at the beginning, because I think without those significant policy drivers, the organisational commitment and a commitment from our professional groups to say, actually, this is a viable career pathway that we want to commit to, then I think the subsequent work that I've been doing and developing my career probably would not have happened. And it's great through the conversations that I've had over the last 3 days that there is a real commitment nationally to clinical academic careers, which is what I'm hearing. So you can disagree with me later, but I think it's a real exciting time. So I registered as a children's nurse, and I qualified back in 2005. I consolidated my practice within general peds and an acute surgical ward, and then transitioned round to children's intensive care, where I found my passion was caring for children and families that were critically unwell. And I suppose what has stayed true to me as a clinical academic is that foundation, that proximity that we have to our patients, to the public, to our families, is a real honour and privilege, and it feeds the whole lifeblood of my clinical and academic activity and programmes of research. And so I know we've got people that have worked in the PICU, but certainly what inspired me to pursue some research was around the conversations I had at the bedside. So this child was called Isabel, or Izzy, and she had meningococcal sepsis. Now, advances to science means that we've got a vaccination for meningitis B and C, but at the time when I was working clinically, we didn't have that, and we'd see these kids that come in multi-organ failure, requiring lots of intervention and support, and we would be having conversations with the family around prognostication. You know, what's life going to be like if they're going to survive? How is she going to be? What are we going to do? And the evidence base wasn't there, so that inspired me to really think about outcomes, and this was at a time when we were shifting our focus. And we've gone through a number of generations in ICU care, adult and paediatrics, where when we incepted our services, it was all about saving lives. And as we become more refined and an expert, we recognise that there'll be a cohort of children or ICU patients that wouldn't be able to survive, and so we needed to facilitate good end-of-life care on the intensive care unit. And then we're into the third revolution, which talks about, actually the vast majority of the children that we serve will survive critical illness. So it's about thinking about optimising outcomes, minimising harm, and supporting these families beyond the ICU. So I was funded through an NIHR and NUH research fellowship to do my PhD, and that was a study that really looked at trying to capture the stories of children beyond the ICU. So it's called the Sketch Study, and it was an in-depth qualitative. We used multiple case studies and serial narrative interviews to try and really understand and explore their concept and understanding of well-being and how that manifested over time beyond the PICU. And for anybody that goes into the PhD, you will understand that you go in with one question and you come out with 50, because there's lots of things that you understand and complexities that you uncover that gives rise to a whole lifetime of research. And I think what we identified from that for the first time was that actually there was difference in the group, but actually there was some commonality in how what needs they had, and that was around traumas and readjustment and psychosocial support. So the PhD ended, and the post-PhD journey began, and you think, oh, well, I'm over this hill, and then the mountain emerges, and you think, oh golly, this is hard going. But I think as a clinical academic, it's about plugging back into your clinical practice, and certainly the community was starting to get behind this. It was a priority for them, and understanding what outcomes were like was important to the nurses and the clinicians that I worked with, and so they kept me going. So postdoctorally, I managed to secure it wasn't a joint appointment, but it was two part-time roles. One working in the Children's Hospital as a clinical academic nurse and research fellow, and as a charge nurse for critical care outreach, and also working at the university as a senior research fellow. So during the postdoc work, what that really focused on was how did this align to practice? So linking it back, constantly having that sort of the synergy between the academic activity and what was happening in clinical care. So we took those 50 recommendations that we got from the PhD study and actually tried to draw some sense and prioritisation from clinicians and other stakeholders, as well as children, young people and their families. And what that identified was that people wanted support, they wanted some sort of navigator role beyond the PICU, and they wanted support specifically within their psychosocial emotional health. So we then undertook a big national survey looking at what was currently offered in practice, and it showed deficits across the board, lack of guidelines, variation in if they did do any sort of follow-up. The content and form of that was not consistent, and actually there was a really distinct paucity of provision of aftercare once they've left the PICU. Concurrently, we were keen to start to develop the theory behind survivorship. And again, this is where leveraging those academic and clinical links was so important. So there's a team of us from an international team that came together to try and conceptualize what had been identified already within the adult populace as post-intensive care syndrome, but the model was not applicable to children and families because there was parts of it that were just incongruent with life course or developmental growth. So we developed this framework based on our research and also our clinical insights, which really has a pathway approach to understanding survivorship. It starts with an antecedent state, so understanding the baseline status of these children and families, and what they are like, what they're coming into the PICU is really important. And I think COVID has definitely shone a light on the social determinants of health, and so that is really very much part of the programme of work going forward. Then thinking about the phenomena, and for us, it's about an interconnected and interdependent phenomena between the child who is critically ill and their family unit, whatever that composition looks like. And then thinking about outcomes across a developmental trajectory, and that they span physical, cognitive, emotional, and social health domains, and can have an impact of survivorship can last from days to decades. So taking that forward in my programme of work, I secured an NIHR clinical lectureship in 2019. So this was just prior to the pandemic. We launched a big national study, which is a mixed methods study that tried to capture and understand the outcomes over the first year post-PICU discharge for these children. And we collected, we did a federated data, so routinely collected data from PICANET, which is our audit data set, collected prospective outcomes from children and families, and also did an embedded qualitative study. And we included, I worked with some fantastic data scientists to help look at that data and use some of the machine learning techniques to really interrogate that data, to look at some of the prognostic factors associated with poor outcomes. And then the qualitative work really helped to build the detail around our conceptual framework. But what we concluded from the Oceanic study was that there was a significant proportion, probably 2/3 of these children and young people that were recruited into the study didn't achieve their pre-baseline, so the pre-PICU health-related quality of life at 12 months post-PICU discharge. There were significant risk factors associated with baseline and PICU characteristics, with outcomes at various time points, and that was a dynamic state. So what was a risk factor at 1 month wasn't necessarily a risk factor at 12 months. And that needs transcended different systems, different individuals, and actually parents and families were moderators of poor outcomes, which I think is very fascinating, considering the offer and support that we give families is minimal, if non-existent. So then that takes me to my current position, which is a joint appointment between the University of Leicester and Nottingham Children's Hospital. I still work and carry a caseload for paediatric critical care outreach on every Wednesday. I have a senior leadership and management role within our care group, and we have a large children's hospital, but other services within that. And then I obviously lead a team and a programme at a university and contribute to some of the education of our undergraduate curriculum. So the lens has really broadened its focus from that PICU, connection to my clinical activity, to thinking more broadly about children and young people. And for anybody in the child health space, we know that children and young people are a third of the global population, but 100% in the future. And so taking on the WHO life course approach, we know that for every pound or euro we invest in optimizing children's lives, we will recruit tenfold in adulthood across economic, societal, and health benefits. And so absolutely fundamental, the why statement of my programme is around optimizing the outcomes and lives of infants, children, young people, and in particular interested around the acute care interface. So how I do that is it transcends the clinical practice and research, as well as education and strategic leadership. I report directly to my director of nursing and advise and support some of the policy and strategic plans that we have embedded within our children's hospital. I'm also the lead for research and innovation within the children's hospital, so help with supporting research delivery as well as research leadership, and have a growing cohort of pre, post, and doctoral students. Within that programme, there are domains which are very clearly aligned to our clinical priorities. And so we know that 75% of all under 18s will have at least one presentation, and that's not just being born in a hospital, it will be in addition to that. And so what we try to do is arrange the programme of research so it is absolutely clinically aligned to our clinical priorities. So we have a programme around harm-free care, which includes children and people's mental health in acute care, falls, skin integrity, medication errors, and patient deterioration. There's a programme around supporting healthcare transitions, that's around decision making, but also clinical status and how we support. There's a growing programme around children with medical complexity and how we support families transitioning in and out of acute care. And then finally is the work that I started as a bedside PICU nurse, but that's grown around on optimising long-term outcomes. We've got a real focus, and I've worked with a postdoc physio around rehabilitation and participation outcomes of children with acquired brain injury and survivorship more broadly. Cross-cutting the themes around some of our methodological expertise and our focus. So as a nurse, I'm interested in complex phenomena and also complex interventions. And so we transcend the whole spectrum. We use, again, quite a broad array of methodologies and methods to understand and explore phenomena. So from in-depth qualitative participatory approaches right through to big data science. We're very cognizant of the digital space, and I think that's evident in the CNO strategic plan that we need to be digitally enabled. So working with technology and industry to really think about how we can drive forward inclusive and accessible solutions. And the equality and diversity piece is really important for the diversity of the populations that we serve. And so there are clear linkage between the programme and some of the local but also national policy drivers. And we have the Core 20+5, which is 5 key areas which 20% of the most deprived part of our population are affected by. And also from our national fund, the children and young people are a priority area. So just to bring some of those bits alive, we have obviously post-intensive care syndrome work. I've talked about oceanic, but that has grown more globally. We've had a study in Singapore that's looked at specifically culture and ethnicity in relation to outcomes. We have an NIH-funded study across the US, which includes 30 PICUs, which is a sister study to Oceanic, and we've just completed one in Switzerland, which has been funded by Essicum. We also have some work on sibling inclusion, and Dr. Ashley Butler is at La Trobe University, and she's an Australian Research Council funded postdoc, so she's leading that work. Children and young people presenting to acute paediatric care is an absolute priority, a national priority. We've had some really damning national reports that have identified real safety issues. The environment and the healthcare interaction isn't optimal. And so on the back of that, we've tried to we've been doing over a decade's worth of work to try and understand and explore people's experiences of acute paediatric care, tried to upskill the staff. We developed, co-designed an educational intervention and tested that with staff. And then we've developed some instruments, it's called the SAFE instrument, and did a psychometric validation study to identify safety concerns. And then more recently, an NIHR-funded study to develop a pathway, an evidence-informed pathway of what interventions should be implemented in line with safety status. The other programme of work is around failure to rescue, obviously aligns to my clinical role as paediatric critical care outreach. And we've done quite a lot of data work around antecedents, so looking at those unplanned admissions to PICUs or the emergency 2222 calls, and looking back at the case notes to really unpick if there was anything that we have missed or whether there was a lack of track and trigger. And what we've seen, you can see by this run graph, is that we've gone from 25% failure to rescue to oscillating between 0 and 3%. So we're very much in the refinement stage. And I know the graph only goes to 2019, but if we continue to plot the dots, it would be the same. So we've had these big hits of implementing electronic early warning scoring systems, doing a lot of training and education, and we have sepsis screening in the background of our electronic system. And so the refinement is really around how do we work with our stakeholders. A lot of the antecedents reports identified that those kids with medical complexity, so may not be aligned to what a normal observation is, but may become very sick very quickly. How do we understand and enable families to escalate their concerns? So we have developed something called the FAR app with our underserved communities, our non-English speaking communities, and we've translated that FAR app into Urdu and Polish, which are the two prevalent languages in Nottingham, to enable parent escalation. And we're currently about to pilot that within the Children's Hospital. So that's a bit of a whistle-stop tour into my career pathway and some of the activities that I undertake as a professor that is a clinical academic. But I think just to end the presentation, I wanted to offer some reflections that could be applied to your context. And I think I talked about this yesterday, but context is absolutely king. I don't think there are two clinical academics that are the same. I mentor and coach a lot of clinical academics nationally, and while there may be synergy and similarity in what we're contending with, how the roles are operationalized within that context will be very different. And so I think it's really important when we're thinking about deploying and enabling clinical academic roles within the organisations that we work in is understanding what do we want the role to do, who are we serving, what's the organisational context and readiness for those sorts of roles, and obviously what health system and country that's in, and that will really shape, you know, the why statement. Why have we got the role, and what does that role need to achieve? Again, I talked about this yesterday when I met with some ANPs around articulating the why, and the why statement is really quite powerful in trying to drive change. So if we're trying to embed a new role or new career pathway within an organisation, trying to get alignment of why we're doing that is really important with wider agendas. And there is some neuroscience behind it. It satisfies more deeper structures within the brain, which is more compelling. So I just put this up here. Does anybody know where this is a why statement? Anybody seen this? No. So this is actually the why statement for the School of Nursing. Yeah. And as I was sitting waiting, we were waiting for our taxi yesterday, I saw it on a banner. And I thought, actually, this is compelling because this is unifying, right? I can relate to that why statement. That would be that I could use that why statement. So transforming healthcare to create a better future for all through research, through education, through knowledge exchange. It is a unifying thing. I think everybody could relate to this. This is why we do what we do. This is why we get out of bed in the morning, because it's quite a unifying approach. We want things better for all. But I feel that was just interesting to pull out. I did wordsmith a couple of the joining words. But I think being able to articulate the why for why we're doing, creating a career pathway or embedding it is really important. And I think some of the success that we've had, certainly in Nottingham, is trying to make this an embedded agenda and not a standalone is really fundamental. So this is we have a strategic nursing plan, and these are the four domains of the plan: research and innovation, and these are the objectives. And actually, the clinical academic careers fit very clearly within that plan. And so when you weave it into the fabric of something, it's really difficult to take it out. The other thing to say is around strategic alignment, and these on this slide are my chief nursing officers in the middle, and I had Joe Cooper, who was my head of research and innovation. At the top is my directors of nursing, and then at the bottom is my head of school or director for research. And these have been absolutely pivotal in getting them around the table. So they're absolutely aligned to what they want from the role, what is achievable, what are the deliverables. So having that strategic and senior buy-in from the outset is absolutely fundamental. And I think if there are challenges at that stage when you're trying to get it onto a page, then to operationalize it into a person is going to be even more challenging. But I think conventionally bringing those silos together is really useful and can, you know, help build the foundations for bigger and better things in addition to the clinical academic work. I think, as I said at the beginning around context, we are shifting our thinking, we're shifting our care delivery to systems thinking, and I think we also need to think differently as to how we operationalise clinical academics, and currently they've sat within organisations or across organisations, and I think maybe there is scope for us to position clinical academics at a system level, and then they can drill down for their clinical in certain parts of the system and then leverage up their leadership and activity across the system. But we do need to be thinking more system-wide and bringing people together. So the clinical focus may be different, but actually our ambition may be the same, or the challenges that we're contending with around knowledge exchange or getting started on a project may be the same. We're certainly better together. So That segues nicely into thinking about collaboration, and I think conventionally we've been in this sort of the top one, multidisciplinary, which is great. But I think for true collaboration that really pushes us into developing new paradigms and thinking differently. And I think the challenges that we're contending with require us to really be disruptive in how we think. We have to get into this convergent space. So some of the work that I've done is working with different disciplines and sectors, certainly in computer science, in industry, and thinking and learning of how they do stuff and how that could be applied to our context. And yes, I'm very proud and to be a nurse, and I bring my nursing to my research and to my clinical practice and to my leadership. But actually, I do science as a team. And so I have some fantastic methodologists and topic experts, as well as people with lived experience that are actively part of my research team. Yeah, so a lot of my projects, I have either parents or children and young people as co-applicants on the research, and I think that brings challenges, but also different perspectives, insights, and shifts us closer to this convergent space that we need to get to with collaboration. I think the other thing around the success of clinical academics is shifting from projects to programs. And I think that's a strategic lens in which we can apply to clinical academic careers. So those priority areas that we conceptualize through consultation with quite a wide group of stakeholders enabled us to really define what those programs were. And I think that is about legacy, it's about capacity building and capability development. And so if we're not thinking more strategically from, oh, let's do this project and then we'll jump to this project, but actually how can we build a critical mass? How can we build a focus and program of research that takes us further down the research continuum, then we're not going to realise the true impact of a clinical academic. So I think that has been really useful to start to conceptualise that, and certainly with my postdoc clinical academics, I do some work in trying to help them to map out what their programmes look like. And then I talked about this yesterday, but being really strategic with building the career, and I've developed a framework, which is a mnemonic called the Ideas Framework, which you can scan the QR code, it works, but helps you sort of frame your thinking around how you can build that career, who you need around you, around your influencers and enablers. Are they the strategic leaders? What are your what's driving you? And I think also thinking about clinical academic posts, what is the driver behind the post? Is it about patient need? Is it about service development and clinical transformation, or all of the above? But those significant drivers need to be really well defined, and then the ambitions for the service and the individual and the organisation need to be articulated. And then finally, for me, I think, you know, as somebody who continues to work clinically, it is absolutely a gift to have that proximity to patients, and keeping them central to everything that we do is so fundamentally important. And so I talked about Isabel, and I still think about her. She's, you know, probably 25 now. Well, actually, this is her now. I don't think you can see that, but she, yeah, ended up with multiple limb amputations due to the meningococcal sepsis. But she didn't just survive her critical illness, she thrived and had a good outcome. She is a TEDx speaker, she's a YouTube sensation. I think she does makeup on the YouTube. But she's a real sort of inspiration for the program of work and the work that we do. So I think just to conclude before we go into some discussion, I think from my insights and experience as a clinical academic over the last 20 years, moving from this space of we're talking and we're engaged with clinical academics to actually making it a reality, it does take time, but it starts with an ambition. And I think I'm really feeling the ambition and the appetite for clinical academic careers over the last 3 days, which I think is really exciting. And I think there is real strategic intent. So it's about mobilising that. We do have to be disruptive. We have to think differently in our leadership. And I think we just have to be really authentic about that. And it may be that it's not the right time for certain organisations to lean into that space. That time will come, but it is a movement. And I think it's about starting small and then building from that. But thinking really differently and asking questions and probing with that and reframing it if you don't get the right response. And then I think fundamentally it's about the why. So if we're really aligned across our organisations with the strategic mission and vision and can see that within the activities and deliverables of those clinical academic roles, then it's really more easy to demonstrate impact. And I think that will really get some traction when you're trying to mobilise clinical academic careers. So I'm going to pause there if that's okay, and we can open it to the floor for some questions or comments or discussion. Yeah.
Sure.
So that's one. How you doing? Thanks very much. Very, very interesting. I'm just nursing as a team-based course. So I'm going into Martin and I work as a director of nursing for research education innovation in Dublin. And I'm actually due to talk about using all this, but
okay.
I'm interested in as a nurse, we're used to working in teams. When you go back to your clinical area, how do you remain embedded within the nursing team? Or is there a risk of isolation from the wider nursing team that you're sort of, you're in that middle third space somewhere between, professor or nursing who's not part of the nursing team? Is that, have you experienced that?
Yeah, and I think that's something it's an active process, isn't it? To be visible and accessible, but not too accessible because then you don't get any work done. But I think, it's something that you have to really be committed to. So, my clinical time on a Wednesday is earmarked for a caseload. And so I am visible part of that office. I carry the bleep and the phone and whatever, and I'm truly embedded. And then I obviously have leadership and management roles that transcend the care group. And so I'm working with a different group of a network of people and leaders. But I think it's that sort of transformational leadership that you need to demonstrate, as a clinical academic and employ. But it's not an easy thing to do. And that's why I think it's so important that you are aligned to the wider agenda. So if there is a service mission, then that clinical academic is embedded within that mission. So they're not seen as an other or an add-on or this is, when money gets tight, you're the first one to go because you're seen as not part of the core business. Does that answer? Yeah.
Yes, thanks much.
Hi. Here. I just want to ask, we're looking at the pillars of consultant and advice, competition advice, and the UK. The whole pillar is then research and translate research practice. So where is this line with those roles that we have in those countries?
Yeah, so I think we are currently doing some work around advanced practice roles and the research pillar, because that is oftentimes very underdeveloped or neglected. Because the priority is around patient care or filling the rota or whatever. But I think there's nothing, clinical academics, you could be a clinical academic manager, you could be a clinical academic direct care nurse or an advanced practice nurse. So there isn't anything to stop somebody, irrespective of what their clinical role, doing a clinical academic career. I suppose it's just about how do we support people that may be very advanced in their clinical or leadership role to upskill in and become more sort of equitable across the domains in their research, and that, you know, we haven't got a quick fix for that, because we've got some very experienced staff that have developed through the AMP route in our organisations that want to step into research, but they're too expensive, or they can't fill the rota, or whatever. So does that answer the question? Or
Yes, it's great. I'm thinking it's the expectation that we are as an organization within the country.
yeah,
Do we part of that and program if the path or the better opportunity, I suppose, between hospitals and the university. And that we possibly need to be developed that whole as well.
yeah, I agree. And I think conventionally what has happened for people in consultant level roles or advanced practice roles is that they may have been doing something that's badged as research, so maybe audit or service evaluation, which is part of the continuum, but not actually leading research or being a named PI on somebody else's trial. But I think what we want for clinical academics, it's about really driving forward and leading that research agenda. So it's about what's pertinent to your practice, and then how are you developing the evidence base to make it more efficient, improve the outcomes, the quality experience of care. And I think that sometimes there is a bit of a mismatch, and that may be because of capability, that they haven't had that, you know, the doctoral level training. So actually they don't know how to lead research, or it's about capacity. And that's a constant tension, isn't it?
So that's really good. I think, like, just on your point, from I work in academia, I work with charity now, and we used to be clinical, but I think it's developing those relationships as well, because we have skill sets as academics to help you do research. So I think strengthen those relationships. Is that your experience, like with the universities and educational authorities? Because we can bring so much, but it's actually getting our foot in the door and so, but being able to have the opportunity to support nurses in their journey as well.
Yeah, and I suppose it pays reference to the point around team science, so we don't have to do it all. And there's research that I do where we have nurse consultants or consultant physios that come on and provide that expertise, and that's part of their research pillar. But I suppose if we want to really advance in this space, and people, you know, are ambitious and want to lead research, then it's about understanding what can we do to enable that to happen, and whether it's about, yeah, working with people, mentorship, coaching, and also, you know, the doctoral program, which is the research training, or getting some time in your work plan so that you can actually do the research. Those are the things that can happen. But I think universally we're challenged, and we have that within the context and organisations that I work in.
Would the focus on research not be, I mean, it's noble enough, but what about evidence-based practice? Because for clinicians, it would be clinical audit or involving a group. There's more to it than just doing research. I mean, taking your role probably taking months and months to get ethics approval to do research, whereas you could have a really good clinical audit program up and probably presented and published. And so is research not sort of a constraining factor in terms of looking at the evidence-based aspect of it?
Well, for me, no, it isn't. I don't constrain it, and I don't sort of discriminate. I think, you know, it's a continuum, isn't it? And it's about trying to enable that to happen in a research environment and culture, and whether that is audit or the service evaluation or quality improvement, or primary research. But I think it's about recognising that we don't just want to sit in that space. There is value of audit, and I get that, but that's about informing the questions, the empirical questions that we need to answer through robust science. And so it's about how do we build that in, and clinical academics, you know, from my sort of expectation of my clinical academics is that they are the the enablers, they are the leaders for that pathway. The knowledge exchange bit is really fundamentally important as well, and we have a responsibility as clinical academics to make the evidence accessible. And I think that's what some people are really put off by, is that, you know, there's jargon and statistics that are reported that people don't really understand. So it's about how do we create that sort of workflow so that the clinical academics can help support in a sort of team science way the mobilisation of knowledge into clinical care, and then not stopping there, but also evaluating the impact and outcomes of that.
Joseph, can I just ask you about, a lot of roles fail because of the demand of people's time, and you're saying your Wednesday is your clinical day. How self-disciplined did you have to be when you started the goal to maintain that? Because it's an encroachment into time continues.
Yeah, I mean, I think you have to be very disciplined. I've got some very clear objectives that I have to deliver on, and the clinical bit, the clinical competence and role is one of the deliverables. And I was very clear about that, as were my two line managers. But yeah, it's an active process. It's not something that's done, you know, defined and done, that you have to keep on revisiting it. Some things may not work, you know, the capacity issue, and certainly there are, you know, we're in a busy period, aren't we, at the university marking, so there will be ebbs and flows, and so it's about being cognizant of that and trying not to break the person in the process, but also being quite ambitious and clear around the deliverables is really important. Yeah. Go for it.
That is much of time on the road later. And of course, obviously, the planning or those in terms of or the targets and first years beginning and all that. But do you think sometimes in these roles, particularly in European sites where they're trying to get more money back, and you need to let the viewpoints, and we need to look at the infrastructure and the governance structures and how they enable or do to that sense.
Yeah.
I think sometimes we talk about challenges of the roles and retention in the roles and success of the roles, but the role is not just the role is happening in space.
Yeah.
If the space isn't conducive to it. So I would just would like to flip the lens and investigate that bit.
Yeah, I mean, I think that's why I say context is key, isn't it? And so the starting point of where you're establishing a clinical academic, it may already be a research enabled environment. And so you're going to get traction pretty swiftly. But if actually you are starting from ground or sub-zero, then that needs to be built into what we expect that person to deliver and perform. So the groundwork, and as I said, this is 20 years worth of activity across the Children's Hospital and the HEI. So it's not a quick win, but it can be done. And I think, you know, it's exciting. Like, we can all focus on the negatives. I mean, everybody could tell me a negative or a problem, but I think, you know, actually the opportunities, the support, the ambition is tangible. And so take that, mobilize that excitement. There will be challenges, but you can overcome that. And I think if you've got collective voice to mobilize the collective action, then it can be done, and it will be done. Yeah.
To what extent does your clinical practice sort of have an influence on your research agenda? So is it that, you know, I know we talk about PPI in Ireland and sort of, you know, children and parents as co-applicants, but how much does the clinical part of your job influence your research?
All of it.
All
All of it.
Yeah. Yeah.
And that isn't just that contact with the family and thinking critically around what that care encounter means, what impact that's having, you know, the feedback that you get when you know, even if you don't ask for it, you're going to get something. It always inspires a thought around, okay, well, we need to be thinking about this, or we need to be doing that differently. But also it's about that contact with the staff and, you know, those informal, because you're in a clinical role, they start talking to you about, oh, I've had this idea, or I've, you know, we were thinking about this quality improvement project, or whatever. So yeah, it's not to underestimate that, you know, the role that you have and the accessibility of being clinical, just because, yeah, I am delivering patient care and I'm carrying a caseload, but also it's feeding the lifeblood of the research. And that's why we've gone down different lines. You know, the antecedent stuff is now really pivotal because we've had some significant policy change around Martha's Rule, which was the child that died in a London hospital, and the unpicking of the culture around that was really hostile to parents' escalating concern. So the FAR app predates that, but has really got momentum now because it's become a clinical priority. But that's only because we were aware of it, we were asking the questions, we were looking for things, and having that clinical credibility really facilitated that. And now I'm on the national, we're doing a national evaluation that's funded by the Department of Health, and I'm one of the, there's a medic, Damien Rowland, and there's myself as the paediatric leads for that work. So I think that clinical currency, the accessibility and the proximity to patients as well as to staff is invaluable. Okay.
Well, that's we might draw it to a close, so thank you so much.
Thank you.